Hello, everyone, and welcome to the fourth episode of our podcast. So far, we've really only discussed the first day or so, but on average, people spend roughly 3 weeks in a hospital, so we know we've still got a lot to cover.
Hello, everybody. It's quite easy to protocolise surgical care and assessment and what happens in the emergency department, make sure that everybody gets a complete package. But once the patient comes back from surgery, things can diverge a lot because people are so variable. Their frailties, their pathways, their expectations, where they come from and so on are so variable that they're all going down different pathways, and it's very much more difficult to describe and define what good rehabilitation is. And I'm going to struggle to do that. It's also very much more difficult to evidence-base it and to produce good research to make sure that it does happen. But we'll try and steer around some of that.
And for Grace, the point of coming into hospital is not just to treat her hip fracture, but to ensure she really recovers from it.
Yeah, we know that surgeons are very good at fixing the fracture, but they also need to fix her so that she can do what she wants, which is to start to get back to independence, start to be able to get up, start to be able to eat, and start to believe in her future.
And I know, thinking back to our second podcast on perioperative care, we know how good surgery really is, or hip fracture surgery really is at, I think, a 99% success rate. But what more can the surgeon and anaesthetist really do to help out?
Yeah, so the surgeon needs to do a good operation, but they also need to document that they've done an operation that allows the patient to weight bear. And around the world, that's not happening. It's pretty standard now in the UK. But around the world, there are many surgeons who will do an operation, but they won't then let the patient get up fully weight bearing. And that compromises their long-term future. So that makes no sense. You've got to have a documented, successful operation as one that allows the patient to get up. The anaesthetist, similarly, is very good at giving the anaesthetics. You've got a very senior anaesthetist doing an operation, doing an anaesthetic that they're very familiar with. They've got 2 hours of one-to-one time with this patient. They're able to focus on the management, particularly of tissue perfusion, which is a big element of what they're doing, balancing blood loss, blood pressure control, hypotensive events with medication, fluids, blood, whatever, and dealing with pain. They're very good at doing all of that. They're very poor at telling anybody else how to follow on from it. So what will happen is that they'll spend all of this time doing that in theatre, but there won't necessarily be any handover to whoever the poor soul is on the ward who's going to receive this patient at the end of the day, which will be a nurse. The middle grades in surgery are probably in theatre or in casualty dealing with patients. So it'll be you. Do you know what you need to do for somebody who comes back from theatre looking poorly?
You're putting me on the spot here. I guess I know there's a few important things I'm going to pull from our previous podcast. So I guess making sure the patient is aware of their surroundings, so that they've got their glasses, any hearing aids, making sure the family is aware of any situations and that they're able to get in contact with their family. And I know topics that we might touch on in future podcasts, such as nutrition. We know how important nutrition is, how important proper pain relief is. I know that I've seen patients in the ward which haven't been prescribed basic paracetamol, and how much of a difference that can actually make. And even just pressure relief, so to ensure that the patients aren't getting pressures, that they're up and moving about, can be very important. So I guess that's what I try to do. Whether I actually do that is another question.
Yes, and the anaesthetist will usually, again in the UK, will usually use a nerve block to try and avoid the patient needing lots of opiate overnight, to allow them to get a good night's sleep after their operation. Pain relief isn't really a major difficulty on the night after theatre, but blood pressure management really is. So these patients, as we've said, can lose 3 or 4 pints of blood during the course of their fracture and their operation, and identifying that that's happening, predicting what that's going to do to their haemoglobin the next day, and preempting a fall in haemoglobin. We ask our anaesthetists in Cardiff to try and ensure that people are topped up so that the haemoglobin's about 90 by the day after surgery. Don't let it drift way down so that it's identified as being very low on the day after surgery, and then transfusion is something that happens a day later. when it's too late to prevent the patient becoming confused, too late to allow the patient to get up. Get in there and anticipate it. But the other thing that you'll need on the ward is you'll need to know what blood pressure you should be aiming for. And that's a secret. It's really very difficult to tell, because when the patient comes in, they're in pain, but they've lost some blood. You don't really know what their blood pressure is. Was it high because they were in pain, or low because they've lost blood? The anaesthetist is very good at judging what the right blood pressure is for them to perfuse their tissues, their brain, their kidneys, and everything else properly. But they don't actually write down what that is, and it can be really difficult. So we ask our anaesthetists, and they're very good at doing this, to document what their target blood pressure is during the time in theatre. You can sometimes guess that by looking at the anaesthetic charts, but they're enormously complex for a nurse and a doctor on the ward to try and interpret. So just get the anaesthetist to tell you what blood pressure you should be aiming for. Lots of these patients don't have a normal blood pressure of 120/80. They normally function at a different level. And that will help you to make judgments about fluid management and transfusion.
Okay, well, I'll definitely make sure I ask every single anaesthetist what blood pressure I should be aiming for. I'm not sure they'll be so happy teaching us all.
Well, but we have a protocol so that the anaesthetists record that as a routine before the patient leaves for recovery. That's not standard, and it is something that I can't say how much difference it's made. It's so useful, and even I find it difficult to know what blood pressure I should be aiming for a patient. So getting them to document that as routine is really important. And then on your post-op ward round day, when you see the patient day one post-op, you're going to be checking to see whether they're delirious. You do their 4AT score, you look at their blood pressure, you look at how that fits with what the anaesthetist suggests. You make sure that people have enough pain relief to be able to move their leg. You don't ask them if they're in pain, because if they're not moving, they won't be in pain. Move the leg and see if they're in pain, and adjust their analgesia so that when the physio comes and makes them stand on the leg, they've got enough analgesia to do so. And we'll talk about pain control in another podcast.
And yeah, we briefly talked about the anaesthetist, the surgeon, myself as a junior doctor. What can everyone else or the rest of the MDT do to really help get this patient back to normal as soon as possible?
Yeah, so we need to keep people out of bed. In the UK, the situation is that people spend on average about a day and a half in bed before hip fracture surgery, and some of that's inevitable. But they also spend another day and a half on average in bed afterwards, and that's not necessarily inevitable. Rachel Banks in our department has done a beautiful piece of work demonstrating you can get everybody up day zero if you treat them, and that's what would happen in elective orthopaedics. The patients would be up on the day of their operation. So why can't we try and do that sort of thing for our patients? So get people up earlier. But that's not all about physiotherapy. Most people get out of bed in hospital because the nurses get them up. The physiotherapists will be guiding and looking for problems and teaching people how to do that appropriately. But much of the rehabilitation is the interaction between the patient and the nurse. And transferring to the toilet is a brilliant physiotherapy session. People stay in hospital until they can get to the loo on their own. So toilet transfers with the nursing staff are really important, which is a good reason not to put a catheter in or to get a catheter out at the earliest opportunity, to enable people to get on with that. So we can build some momentum in rehabilitation at an early stage.
And what's nice, say, on these types of issues?
Yeah, so you want good evidence on all of this. It all unravels a bit because NICE reviews the evidence, but if there isn't evidence, they really struggle. And if there aren't randomised controlled trials of physiotherapy, and if there aren't randomised controlled trials of the cost effectiveness of physiotherapy, it's very difficult for NICE to pontificate in a powerful fashion. So we all know it's obvious that people need physiotherapy after surgery. It would be difficult to do a trial where you didn't give people physiotherapy after surgery. So creating a good RCT-based evidence base is really struggling. What NICE says is that the team needs to function together. All of us, the surgeon, the anaesthetist, the medics, the nurses, the therapists, everybody needs to be working together to try and get people up and moving and believing in themselves at as early as possible a stage.
And is this somewhere where physios take the lead on really getting patients up on that day zero, day one? They
do, and that's very much the area that they're trained. But but it isn't all about physiotherapists doing this, and for them to train other people to do it and to feel confident, other people to feel confident in doing it is fundamentally important. The work that we did with the Chartered Society of Physiotherapy back in 2017, CSP recruited 600 physiotherapists, and they collected data on 6,000 people who had hip fracture, looking at the therapy in the later stages of inpatient rehabilitation and in the community, to look at the quality of rehabilitation that people got. And it was a bit of an eye-opener, really. There were an awful lot of people getting very poor amounts of therapy, and the outcomes were very disappointing. So 2/3 of patients were getting out of bed by the day after surgery, but it was just 2/3. And in some hospitals it was less than half of patients were succeeding in doing that, because pain control was poor, because patients were hypotensive, or patients were confused. So real challenges there that other people, not the physios, need to disentangle. So that work led on to an understanding of hip fracture care, a recognition that people weren't getting very much therapy. They weren't necessarily getting continuity of therapy during their time in hospital. Weekends seem to be a break in many hospitals. And that they were promised community rehabilitation after going home, but on average people waited 2 weeks before they got any therapy at home. So we may get people out of hospital, but do we get people back to independence with community rehab? That was an area that was a failing, and that was identified as an area for work. And the CSP wrote their own hip fracture standards, which define what good quality hip fracture therapy should be, and are an example of what therapy should be in other specialties as well as hip fracture. And as a result of that, we've seen a real change. So I said 2/3 of people were getting out of bed by the first day. Then the figure in the UK is now 82%.
So 82% across the UK getting out of bed on the first day?
By the first day after surgery, yeah. So there's a real improvement in what's happening, because it's still very poor in some hospitals.
And how is it like outside of the UK in other countries?
In other countries it can be very different. So there can be an expectation that the idea of surgery is to mend the fracture, to deal with the pain, but the rehabilitation, recovery and long-term care are something that the family has to deal with. It depends on how your health service is organised, and perhaps we should involve people from other countries in this podcast and talk about how things are organised elsewhere, because there's an enormous amount that needs to happen in other countries, and we've shown the potential for improvement with quite simple things happening in the UK.
I think that's definitely quite interesting. Getting other people involved would be pretty cool.
Indeed. So we've used the CSP audit to try and drive up the quality of care. It's also fed information to other use. So we've used the same information that was collected in that audit in a couple of research papers. The REDUCE study, which is a big analysis of individual patient data run by Bristol University, has done some very nice work demonstrating that hospitals which provide physiotherapy continuously through patients' time in hospital, including the weekends, get patients home 2 to 3 days quicker and much more cheaply. So you can't afford not to be providing physiotherapy at weekends. It's going to be cheaper to provide physiotherapy than not to. So that was a nice piece of work. And as I say, the Bristol, another team in Bristol are running the INITIATE trial, and the INITIATE trial is offering people normal physiotherapy or randomising some of the units to the ability to provide additional, more intensive physiotherapy work on mobilisation, and trying to look at providing an evidence base for enhanced physiotherapy in that. So we've got a challenge in how we start rehabilitation. We've also got the challenge of some of these more complicated patients in whom rehabilitation is really difficult. So thinking about how you do rehabilitation for somebody who has dementia, whose ability to learn is really challenging. How do we do that? And how do we maintain momentum towards independence? How do we avoid families losing confidence in their loved one, starting to think about long-term care arrangements rather than really developing momentum towards getting people back home and independent. And some people spend a very long time in hospital having rehabilitation or having very little rehabilitation, just recuperating without a real sense of momentum. And that can be a drain on them, on their family's morale, their family's confidence in them. And wrapped up in that is nutrition. If people are not eating well in hospital, and they're not, their physical and mental resilience wears away during their time, and recovery is a real challenge. So nutrition is a topic we need to talk about.
Well, that leads very nicely onto our next podcast, which will be focused on nutrition for older patients with hip fractures into hospital. And yeah, again, thank you very much for talking us through the rehabilitation process, Prof. Johansson. Thank you very much for listening, and we hope to see you on our next podcast. Thank you.
Thank you.